hypothyroidism is 2%. The thyroid function in pregnancy. There is increase in the size of gland and around 50% increase in the production of hormones. There's increase in the iodine requirement in pregnancy around 150 to 250 micrograms due to increased renal blood flow causing increased excretion, increased plasma. Estrogen causes in the serum total the thyroid binding globulin, thus total unbound T4 levels increases. Free T4 level, however, remains normal. HCG mimics TSH and stimulates the production of more hormones, thus decreases the TSH, serum TSH, which mimics hyperthyroidism, especially in early pregnancy. In the first trimester, fetus depends on the maternal thyroxine through placenta. 10 to 12 weeks, fetal thyroid starts functioning by making thyroxine from the iodine which it receives from the placenta under the effect of maternal thyroxine releasing hormone. Maternal free T4 is very significant, and 30% of the T4 found in cord blood are of maternal origin. Maternal TSH does not cross placenta, only free T4 crosses the placenta. T4 is required for normal fetal brain development, neuronal multiplication, migration, and structural organizations. Occurs in first half of the pregnancy. Glial cell multiplication, migration, myelination occurs primarily by the fetal supply of thyroid hormones in the third trimester. Types of hypothyroidism. Primary is T4 synthesis and release. Secondary is due to the disease of hypothalamus or pituitary tumors, infection, trauma, Sheehan syndrome, central hypothyroidism. Autoimmune hypothyroidism includes anti-TPO antibodies, thyroglobulin antibodies. Iatrogenic, high dose of neck radiation or radioactive iodine. Subclinical hypothyroidism, where the TSH are high, T4 levels are normal. Isolated hypothyroxemia, where normal TSH with low free T4 levels. Thyroid, maternal risk of hypothyroidism. Recurrent spontaneous first and second trimester abortions are noted. Preterm labor increases by 2 times more than the normal. Increases by 15 to 22% compared to the normal population, so almost 2 times more than the normal population. Placental abruption, there's 3 times more risk in hypothyroidism. There's risk of fetal growth restriction, PPH, postpartum blues, and mixed edema coma. Fetal risks of hypothyroidism include fetal growth restriction, IUD, stillbirth, increased perinatal mortality, congenital anomalies to the fetus, neurological cretinism, cardiac dysfunction, cerebral palsy, neonatal hypothyroidism, retarded physical, neurological, cognitive development. Thyroid screening in pregnancy. There is insufficient evidence to recommend for or against universal screening of abnormal TSH concentrations in early pregnancy. Universal screening to detect low free T4 concentrations in pregnancy is not recommended. All pregnant women should be verbally questioned and clinically assessed for thyroid enlargement. American Thyroid Association 2017 has made a target population for screening of thyroid in this population. If there's a history of hypothyroidism or hyperthyroidism or current symptoms or signs of thyroid dysfunction, known thyroid antibody positivity or presence of goiter, history of head or neck radiation, prior thyroid surgery, age more than 30 years, type 1 diabetes or other autoimmune disorders, history of pregnancy loss, preterm delivery, or infertility, multiple prior pregnancy loss, family history of autoimmune thyroid disease or thyroid dysfunction, morbid obesity, use of amiodarone or lithium, or recent administration of iodinated radiological contrast, or the patient is residing in an area of known moderate to severe iodine insufficiency. Polish and Spanish Society, they recommended universal screening of TSH levels in the first 10 weeks of gestation, and then free T4 level if the TSH was more than 2.5 micro international unit per liter. Their targeted screening is reported to miss 30% of cases of thyroid dysfunction. That's what they reported in this study. But a recent study reported 9.6% of cases of subclinical thyroidism would have been missed by targeted screening. If prospective trials find that treating subclinical hypothyroidism in pregnancy is beneficial, this will support universal screening in future. In 2011, American Thyroid Association, the upper limit actually decided that in first trimester 2.5, in second and third trimester it to be TSH of 3 milli international unit per liter. But recent investigations and they extended the upper limit of TSH to 4 in 2017. And population-based trimester-specific reference ranges for TSH should be defined through assessment of local population. So, in high-risk population, you have to check the TSH as soon as pregnancy is confirmed. If TSH is between 2.5 to 10, we have to reflex test for TPO antibodies. So if TSH is less than 2.5, then you should check less than 0.1, that is less than 2.5 centile, that you should check for thyrotoxicosis. If it's between 0.1 to 2.5, there's no further workup. If it's 2.5 to 10 milli international unit per liter, then you have to test for whether TPO antibodies are present or absent. If it is present, if it's more than 2.5 also, we can consider treating with levothyroxine. If it is more than 10, we have to treat with levothyroxine. If it is TPO antibody negative, then 2.5 to 10, then there's no treatment. Consider treatment with levothyroxine if it's more than 10. If it is more than 10, then treat with levothyroxine. Thyroid antibodies. Euthyroid pregnant women who are TPO antibody or thyroglobulin antibody positive should have measurement of serum TSH concentration performed at the time of pregnancy confirmation and every 4 weeks through mid-pregnancy. Insufficient evidence exists to conclusively determine whether levothyroxine therapy decreases the pregnancy loss risk in TPO antibody positive euthyroid women who are newly pregnant. Administration of levothyroxine to TPO antibody positive euthyroid pregnant women with prior history of loss may be considered given its potential benefit in comparison with its minimal risk. In such cases, 25 to 50 microgram of levothyroxine is a starting dose. There is no role of immunoglobulins. Known hypothyroid patient in the reproductive age group should be counseled regarding the likelihood of increased demand for levothyroxine during pregnancy. In hypothyroid women treated with levothyroxine who are planning for pregnancy, serum TSH should be evaluated pre-conception and levothyroxine dose adjusted to achieve a TSH value between the lower reference limit, that is 2.5, should be considered. Hypothyroid patients receiving levothyroxine treatment with a suspected or confirmed pregnancy the dose of levothyroxine to be increased by 20 to 30% and need for prompt testing and further evaluation. One means of accomplishing this is to administer 2 tablets weekly of the patient's current dosage, 2 tablets additional to the current patient's daily requirement, or you can increase by 25 microgram according to NRHM guidelines. Serum TSH monitoring should be done every 4 weeks in the first trimester, 6 to 8 weekly thereafter. Recheck 4 weeks after any dosage adjustments which are to be done. Aim to maintain the TSH within the range of 0.5 to 2.5. We have to advise the patient to take the tablet on empty stomach before breakfast, and ideally no other medicine should be given 4 to 5 hours gap after taking the medicine. Even calcium, iron, vitamins can interact in the gastrointestinal tract and reduce the thyroxine absorption. If hypothyroidism is diagnosed in pregnancy, then immediate thyroxine replacement should be given. Further investigation for the presence of thyroid autoantibodies should be done. Antithyroid peroxidase antibodies and antithyroglobulin antibodies. Thyrotropin receptor antibodies if there is a history of treated Graves' disease. Starting dose of thyroxine is at least 50 microgram per day. Maintenance between 100 to 150 per day. Aim is to keep the TSH less than 2.5. Dose depends on the size of the patient, the degree of the hypothyroidism, and other medical diseases. Postpartum period following delivery, levothyroxine should be reduced to the patient's preconceptional dose. Advise testing 4 weeks postpartum. Levothyroxine is initiated during pregnancy. The patient may not require levothyroxine postpartum, especially when the levothyroxine dose is around 50 microgram per day. The decision to discontinue levothyroxine, if desired, should be made by the patient and the caregiver. If it is discontinued, then TSH should be repeated weeks. Thank you.
ಸ್ವಲ್ಪ ನೀರ್ ಹಾಕಿ ಕುದಿಸಿಟ್ಟಿನ ಅಂದ್ರೆ ಅದು ಕುದಿಯುತ್ತಲ್ಲ ಸ್ವಲ್ಪ ಕುದೀತಾ.
Thank you, Sneha, for that clear presentation. What I could understand was there were 3 cases, I think. One, a mother who is lady who is already diagnosed to have hypothyroidism conceives.
Yes, sir.
Who is detected as hypothyroidism first time in the pregnancy.
And one who is
subclinical hypothyroidism, right?
Yes. Yes.
Yeah. I think we can have a discussion again about universal screening. When to send thyroid? Are we doing thyroid peroxidase antibodies? What should we do postpartum? I think Basuraj sir is there to give us a better guidance there. So I'll now request my pediatric colleague, Dr. Divya, to share her screen. Divya, can you share your screen? Divya, you can unmute yourself and share your screen.
Yes, sir.
Divya, your screen is visible. You can make full screen it.
Yes, sir. Good evening, everyone. I will continue our discussion. We'll begin with a case scenario. Here is a full-term male baby with a birth weight of 2.8 kg. At 48 hours of life, TSH was done and it was found to be 180 international units per liter. How to proceed with this baby? With today's discussion, we'll get to know how to proceed with this baby. Congenital hypothyroidism is the commonest cause of preventable intellectual disability. Only less than 5% babies are symptomatic at birth, and up to 10% may show symptoms in first 1 month of life. If we treat such babies within 2 weeks of life, near normal outcome is possible. By seeing this picture, anyone can tell it's a case of congenital hypothyroidism, but it is too late. Reference for today's discussion is by recommendations given by the Indian Society of Pediatric and Adolescent Endocrinology. Rationale for newborn screening for congenital hypothyroidism. It is a common disorder and it is more common in India compared to developed countries. Incidence varies from 1 in 1,000 to 1 in 1,500. The screening method is cheap and it is easily available. And the treatment option is inexpensive and it is highly effective. Which sample should be collected? It can be cord sample or postnatal sample. Cord sample, the advantages are being it is easily, it can be collected easily and there is no extra prick is required. And it is suitable for the mothers who get early discharge. But the disadvantages being other disorders cannot be screened. Other option is postnatal sample. This can be used to screen other disorders also, but adequate training should be given for the personnel to collect the sample. And it also needs a reliable central lab and special assay to do the test. Either cord blood or postnatal day 3 to day 5 sample should be used for screening. And if filter paper sample is not feasible, then postnatal peripheral venous sample can be used for tests. How to collect the sample? Cord sample, it should be collected from the placental side of the cord. 3 to 5 ml should be collected and it should be transported to the lab within a day. And next option is heel prick sample. In this figure, you can make out the area where the sample should be collected. And this full screen should be, like blood should be collected through a full circle. And it should not be like this, like half and half circles. Which test to be performed? Two modalities are there. Either it can be primary TSH testing or primary T4 testing. Primary TSH testing is more sensitive and specific for the diagnosis of primary congenital hypothyroidism, but it can miss the cases of central hypothyroidism or delayed rise of TSH. It is adopted by most of the countries worldwide and it is also recommended for India also. Other modality is primary T4 testing. This can identify patients with primary and secondary congenital hypothyroidism, but misses the neonates with compensated forms of congenital hypothyroidism. That is with normal T4 with high TSH, and it has a higher rate of false positive test results. And in some cases, second sample for screening may be required, such as in preterm babies, IUGR, sick neonates, twins, and Down syndrome. In these cases, there may be delayed rise of TSH and initial TSH may be normal. Hence, after 2 to 4 weeks, a second sample is advisable for these babies. In this flow chart, we will get to know what are the values and when to interrupt. A TSH value less than 10 at 48 hours of life or between 24 to 48 hours of life. TSH value less than 34 is considered as normal. If it is between 20 to 40 and values are divided into 20 to 40, more than 40 and more than 80. When it is 20 to 40, baby should be recalled at 7 to 10 days of life for second screen. And at recall, we should test for, if venous sample is collected, then we can test for TSH and free or total T4. And if it is more than 40, a baby should be recalled after 72 hours of life, and TSH, free T4 or total T4 can be tested. And if the value is more than 80, then immediately samples should be taken for the second test, and treatment should not be delayed for the results. Immediately treatment should be started. Then results, it is considered normal, like when TSH value is less than 20 for the babies who are less than 2 weeks of age. And if it is less than 10 for the babies who are more than 2 weeks of age, and the free T4 level more than 1.17 nanogram per deciliter, or total T4 more than 10 microgram per deciliter is considered as normal. When the free T4 is low, that is less than 1.1, or total T4 less than 8 microgram per DL, irrespective of TSH level. And whenever there is a free T4 level is less than 1.1 and T4 level is less than 10 and TSH value is more than 10, treatment should be started. And when scenarios like TSH is raised like more than 20 for babies less than 2 weeks of age, and more than 10 for more than 2 weeks of baby with normal T4. For such repeated, TSH should be repeated, and if it is less than 10, it should be considered like persistent more than 10. Sir, am I audible, sir? Sir?
You're audible. In between, we lost your voice, but you're audible now. Share your screens again, Divya. Can you share your screens again?
Sir, till when it was, I think, in between my internet
The
got
flowchart.
flowchart. Okay, sir. Okay.
You can share the screen again. We have lost your screen. Yeah.
Yes, sir. Yes.
You're able to see your slide number 12. Can you make full
Now
screen?
visible, sir?
Yeah, it's visible.
Okay.
Make full screen.
Yeah. Yes, sir. In this flowchart, we'll know about the values when to act. It is TSH is less than 10 at 48 hours of life, and
you can move to next slide.
Next slide.
Next slide, I think.
This slide. Okay. Yeah. Causes for deranged thyroid function test. When thyroid function test showing low free T4 and high TSH, the causes can be a permanent primary congenital hypothyroidism, or it can be transient primary congenital hypothyroidism. When T4 levels are low with the normal free T4 and normal TSH, but total T4 is less, the cause may be thyroid binding globulin deficiency. And when free T4 level is low and normal TSH, it can be because of central congenital hypothyroidism or transient congenital hypothyroidism. And normal free T4 levels and high TSH, it can be because of compensated primary congenital hypothyroidism or transient primary hypothyroidism, endemic iodine deficiency, inactivating mutation of TSH receptor, normal free T4 and delayed rise of TSH. This can be because of preterm or sick babies with primary congenital hypothyroidism, and also can be because of endemic iodine deficiency. And then coming to etiology of primary congenital hypothyroidism, it can be transient or permanent. Permanent is because of thyroid agenesis or dysgenesis, ectopic thyroid, or thyroid dysharmonogenesis. Thyroid dysgenesis being the most common causes. Approximately 80% of the cases are because of thyroid dysgenesis. And the transient causes such as maternal thyroid antibodies, iodine deficiency, maternal antithyroid medications, and iodine exposure. Less common causes such as central hypothyroidism and resistance to thyroid hormone. Coming to imaging in congenital hypothyroidism, with confirmation of congenital hypothyroidism, treatment should be initiated, and thyroid imaging should be done to identify the etiology. Imaging of thyroid gland can be done by either ultrasonography or nuclear imaging or both. Imaging should never be the cause to delay the initiation of the treatment. Scintigraphy may be done within 7 days of initiation of therapy, and ultrasound can be done even weeks or months after treatment is initiated. If thyroid scan was not done at the time of diagnosis, it may be done at 3 years of age when permanency of congenital hypothyroidism is established prior to restarting the treatment. USG of thyroid gland is done, and it may show absent gland, small gland, enlarged, or normal size gland. Absent gland shows that either it can be because of thyroid agenesis or because of ectopic thyroid. And when the thyroid on USG, the thyroid gland is small and thyroid scan showing absent or reduced uptake, it can be because of thyroid hypoplasia. And the gland is enlarged and thyroid scan is showing increased uptake. It is because of endemic iodine deficiency and reduced uptake in thyroid. It is when maternal antithyroid drugs are because of maternal antithyroid drugs, and reduced uptake in thyroid, salivary, and gastric mucosa. This is because of sodium iodine importer gene mutation. And normal when there is normal uptake, perchlorate discharge test to be done to diagnose dysharmoniogenesis. When normal size is detected in your USG of thyroid gland and thyroid scan showing increased uptake, this can be because of endemic iodine deficiency. And there is no uptake in the thyroid, that can be because of thyrotropin binding inhibitory immunoglobulin associated congenital hypothyroidism. No uptake in thyroid, salivary, and gastric mucosa. This can be because of sodium iodine importer gene mutation, and reduced uptake because of perinatal exposure to excess of IOD. And reduced or absent gland size may be slightly small. This can be because of TSH receptor resistance. Coming to treatment. Treatment should be started as early as possible. If it is started within 2 weeks of life, that is like near normal neurodevelopmental outcome can be possible. Treatment is given in the form of levothyroxine. Even though T3 is the biologically active form, treatment is given only by the levothyroxine. In brain, locally it is converted into T4 to T3 by monodiadenase. The standard dose of treatment is 10 to 15 microgram per kg per day. Should be initiated depending upon the severity of the congenital hypothyroidism. In severe cases with the very low T4, the initial dose should be on the higher side. The goal of the therapy is to normalize free T4 within 2 weeks and TSH within 1 week of starting of the therapy. Tablets should be crushed in small quantity of breast milk till 6 months of age, and after 6 months, either breast milk or water can be used, and it should be directly administered with a spoon. Tablets should not be added in the feeding bottle. Avoid iron, calcium, soya, or vitamins within 3 to 4 hours of administration of thyroxine. All these should be clearly instructed to the parents, and their written guidelines should be given to the parents. In follow-up, at 2 weeks after starting the treatment, the T4 levels should be checked, and at the 4 weeks of starting of treatment, free T4 and TSH level should be checked, and T4 should be maintained in the upper half of the range, reference range, and by 2 weeks of starting of therapy, and TSH in the lower half of the normal range by 4 weeks of starting of therapy. Further follow-up should be done at every 2 weeks till 6 months of age, and every 3 months during 6 months to 3 years of age, and every 3 to 6 months thereafter till the growth and puberty is completed. And if any slightest doubt, test should be repeated. This is the table showing age-wise reference value of T4 and TSH. This is also the same. During follow-up, T4 and TSH, target T4 should be in the upper half of the reference range, and TSH should be in the lower half of the normal range. Growth and puberty should be monitored in every visit. Growth and weight should be plotted on the growth chart, and in older children, Tanner staging should be done, and developmental assessment should be done in each follow-up. If high TSH is shown in the follow-up, then compliance of the thyroxine should be checked, and administration technique should be inquired for, and ask for history of co-administration of substance which may impair the absorption of thyroxine. High TSH in the presence of high normal or high T4 shows chronic poor adherence, followed by making doses before sampling. Rechecking for the permanency of the congenital hypothyroidism. With respect to transient hypothyroidism, recheck for permanency of congenital hypothyroidism and stop thyroxine for 4 weeks and recheck T4 and TSH. If TSH is more than 10, imaging should be done if not done earlier, and treatment should be restarted. If TSH is between 5 to 10 with normal T4, a patient should be referred to pediatric endocrinologist, and if TSH is less than 5 with normal T4, it is because of transient congenital hypothyroidism. Then regular follow-up should be continued for such cases. Coming to conclusion, every newborn must be screened for congenital hypothyroidism. Screening can be done either by cord blood, postnatal heel prick, or a peripheral venous sample if filter paper is not feasible, taken at 48 to 72 hours of life. Infant with screening TSH showing more than 20 should be recalled for confirmatory sample. TSH more than 20 in the first 2 weeks and more than 10 beyond 2 weeks of age with low T4 suggests primary congenital hypothyroidism. Treatment is given with levothyroxine tablet at the dose of 10 to 15 microgram per kg per day as a single daily dose. Thyroid imaging is desirable but should not lead to delay in the treatment. Thank you.
Thank you, Divya, for that clear presentation on when to treat, the role of screening TSH versus T4, and the importance of treatment, early treatment. So I think let's open the house for questions or any discussion. Do you want to make any comments before that? Basraj sir?
Yeah, hi. Can you hear me now?
Sir, we can hear you, sir.
Yes. Very nice presentations by all three. But see now, that's what, like, there are a couple of things we need to discuss a lot here. In adults, the reference ranges were again spoken of. So 2.54, there are so many confusions. So whatever the newer ADA guidelines actually has come up with upper reference range during pregnancy of a TSH of 4. Nah? So most of that data is from the Western population. And so we do not have any of the Indian population data to support that also. So most of the endocrinologists, we still believe the initial 2011 ATA guideline 2.5, less than 2.5, less than 3, as are still cutoffs hold true. But yes, ATA has also come up in its 2017 that 4 can also be sought, but we do not have much evidence suggesting that there. So probably we'll still be more conservative and we'll keep the reference ranges as 2.5, less than 2.5 of TSH in the first trimester and less than 3 in the second and third trimesters. So role of antibodies is also there, anti-TP antibodies, anti-TG antibodies. So they help in deciding in the subclinical hypothyroidism cases. Probably if they're positive, we tend more towards treating, and probably if they're negative, we tend more towards not treating. Definitely more than 4, we will be more towards treating the mother. If at all she has any history of recurrent miscarriages or anything of that sort, any high risk pregnancy and high risk characters, if we see, then we'll be more towards treating if the TSH is more than 4. But again, having said that, TSH of 2.5 to 4 and anti-TPO positive with an euthyroidism, apparent clinical and biochemical euthyroidism, TPO positive, there is again conflicting data that treatment might help, treatment might not help. That again will have to, that again is a big debate by itself, but let us not go into those things. But definitely more than 4 and any anti-TPO antibody positive or any anti-TG antibody positive, I would definitely treat. And in those areas where actually the monitoring and other things are now scarce and we are not able to reach out to these patients very frequently for testing. So what NRHM told